that your scoring system for UCIS is going to be really important, I noticed that there's not a distance component to it. And of course, that's what made the CEIS so complicated.
Oh, absolutely so. So, well, precisely, Ellen. And as you've gathered, I'm a simple soul, and it was exactly thinking of the CDIS. I said, if my name's attached to something like CDIS, thank you very much indeed. It's too complex. However, having said that, I think what we advise is score the most severe area on, and we're doing flexies. What Bill has done when he was at the Mayo was to actually look at segmental distribution. He's already published that using the UCIS prototype, and looking at a cumulative scoring akin to the CDIS. I think that's an opportunity to do more now that we've got this UCIS validated just for sigmoidoscopy, just for the worst affected area, then to roll it out and to say, well, perhaps if we divide the colon into 5 segments, that we can see whether that we can get a better idea of the overall burden of disease. And I think that is an opportunity. But the reason we didn't go there was we first of all, we only had flexies available in the video library, and secondly, we thought, well, let's see if it can work for this before we try and make it more complicated. Yeah.
In an acute setting, that's probably all you're going to have anyway, is the sigmoidoscopy.
Well, I think so. No, and that's true. But this goes for any patient with colitis, and of course, and you not infrequently get a degree of rectal sparing, especially if they've been used topical therapy. But for this, it doesn't matter, because if they've got bad disease in the sigmoid, then you score the bad disease, really. Yeah. Okay. Good. Yes.
One more question. You used a biologic definition for acute
severe
colitis, meaning diarrhea greater than 6 bowel movements a day, and one of those other criteria. But practically, you seem to use those patients admitted to the hospital.
Oh, no, sorry, I should have explained that in Oxford for decades, the people we admit to hospital are those with those true love and wits criteria. We use true love and wits criteria as the threshold for admission. Now, practice hasn't changed at that time, and I agree that we excluded people who didn't meet the true love and wits criteria. We called those moderate disease, and so we did not include those as the ASC cohort.
And have you been able to stratify those patients, either that you admit or with acute or serious colitis, for prior therapy or duration of disease?
So we looked at that and couldn't. It's probably because numbers became too small, even with really quite a large cohort. So we really thought, well, could prior therapy, if they came if they had azathioprine when they came in, did that mean they're more likely to come colectomy? You'd think the answer was yes, but in fact it didn't reach significance when we did it, and I think again because numbers were too small. And then what we had difficulty in doing was whenever you're talking about thiopurines, it's how long were they on for it, how was the dose titrated, and it gets very, very murky. Yeah. Go on.
This may be a naive question, I'm a transplant oncologist, but what's the magnitude of the additional prognostic value of the endoscopic severity on top of the clinical indices?
Of course, it's not a naive question. I think that we don't know is the answer. All we've done with assessing the severity with the UCIS is validate a spectrum so we can all be talking the same language, because, believe me, that when you can't rely on what somebody else is describing, and so I encourage my trainees always to describe what they see and then interpret it, because if I see an endoscopy report saying endoscopically moderate ulcerative colitis, what does that mean? What do they actually see? I think now that we've got a common language, we can go and answer that, and that will come up with the trials. And of course, it throws into question all these other indices for ulcerative colitis. How does this fit in with the Mayo Clinic score, where you've got their own Mayo Clinic endoscopy subscore? Well, I think we'll discover that answer when we when we've got trials which are in planning at the moment, phase 3 studies, which are running the UCIS alongside the Mayo Clinic score, and then we'll be able to answer that. And I think where we'll go to, ultimately, is having separate indices validated for clinical symptoms, for endoscopy, for histopathology, for quality of life. And I think that sort of makes sense, because at the moment we use, out of the 9 different activity indices, they're the unvalidated indices, and then they get broken down into subscores. What is that? Statisticians groan about that, and I think they're probably right to. So I don't know the answer to that, and I think that with the cohorts we will be able to apply. Well, if 3 is normal, in other words, 1 for vascular pattern, normal vascular pattern, 1 for mucosal bleeding, no mucosal bleeding, 1 for erosion ulcer, in other words, no erosion. So 3 is the lowest. That clearly is normal or remission, and it may be 3 and 4 should be remission, and it may be 8, 9, 10, 11 should be severe. We're still working around that, because it depends a little bit on which component and the relationship between components as to where the overall score is. So we're working on that at the moment.
Well, I think a lot of people have to run to clinical duties, but I want to thank Simon for coming. And in future months, we'll have 3 further visiting professors, Tom Ullman, Ed Loftus, and David Rubin. I hope you'll all be able to make it.